Thank you all for coming out today. And as you can see, the title of the talk is Socio-Structural and Socio-Cultural Model of Racial and Ethnic Health Inequalities. Or alternatively, why black and white might not be so black and white. And to be completely honest with you, I am more interested in giving a talk than I am a presentation, right? So I'll start by way of introduction, and I was planning on doing this anyway, so it works out. I am originally from northeastern North Carolina. I grew up on a small farm there, tobacco and cotton. And my mother tells me that when I was born, she self-identifies as Black American. Tells me that when I was born, that my father, who self-identifies as Black Indian, he's from Halifax County. You know, any of you familiar with the Saponi people, Aloha Saponi, Native Americans? Tells me that my father showed up at the hospital late and got into an argument with an Italian man there who had mistakenly identified me as his son. When I was a child, because my parents thought it was important, I got to be both Black and Indian. And when I was a teenager, we moved off of the farm into an all-black trailer park where the kids there told me that they weren't dealing with any Geronimos, so I could not be Indian, and that I was and could only be Black. Years later, when I finished college and went off into the Peace Corps, I had the opposite experience. The people there told me that I was not Black, but instead Trigueño, which is a different description, or a different higher status actually, description of my mixed heritage. And the reason they did that is because the skin color gradations that determine social stratification, at least in Honduras where I was, are significantly more nuanced than what we have here in the States. And they were looking out for me. They wanted to make sure I was aspiring to my highest possible color status. And the first time someone asked me what I was and I said Black, he hushed me, went shh, and pulled me aside and said, "Don't say that again." So, really interesting stuff. And more recently, because I do research, or I've done a paper, and I'm currently actually working on another project on Jewish identity. Other people have asked if I was Jewish. And so, as you might imagine, these experiences have influenced my research agenda and actually my academic pursuits also. And the lessons that I've learned from those experiences is this variable process of racial assignment and ethnic identity formation, right? And what I learned is that how people view you and how you in turn view yourself and the social connections you make as a function of those two things has implications for access to resources that can be health enhancing or exposure to insults that can be health compromising, right? And that these in turn influence quality of life and well-being over the life course, right? So again, why black and white might not be so black and white. So in terms of health inequality, where do we stand? Despite efforts to offset health inequalities between black and white Americans, they remain entrenched and in some cases are actually getting worse. For instance, the two leading causes of death, heart disease and cancer, have seen increases in the differences between these two populations over the past 30 years or so, right? And disparities in birth outcomes are particularly troubling and really resistant to change. And this, in part, due to the fact that interventions to actually reduce the differences between black and white Americans have resulted in larger and more rapid improvements among white Americans than among black Americans, resulting in a net increase in the difference between the two populations, right? So why are we stuck here? I suggest that major contributors to these and similar phenomena are over-reliance on narrow approaches to redistribute conventional socioeconomic resources, a lack of careful consideration for the constructs of race and ethnicity and related racial structural barriers, and the general absence of culturally appropriate efforts to eliminate these differences. Combined, these phenomena result in interventions and efforts that may be relatively better suited to offset socioeconomic health differences within white Americans than to do anything about racialized health differences across the various populations of color here in the U.S. Right? To overcome this impasse, I argue that we need new, more representative conceptual models and frameworks which will guide this work and more accurately reflect the lived social experiences of all populations, both mainstream and marginalized, including those of color, reinterpretation or more careful consideration of compelling existing findings, and new empirical investigations that are informed and guided by this framework. So to these ends, during the rest of today's presentation, I will provide a brief historical review of socioeconomic status and health, examine contemporary perspectives on the relationship between race, ethnicity, SES, and health, highlighting tensions and contentions between the constructs, introduce and explicate a conceptual model which strives to resolve and reconcile some of these tensions and contentions, and present select findings from some empirical investigations that I've worked on and I'm currently working on that were informed by and test different components of the framework. So, as we all know, a core tenet of health inequalities research is that there exists a direct and robust relationship between socioeconomic status and health, whereby one or some combination of education, occupation, income, measured at the individual, community, or household level, predicts health. We observed rapid improvements in health from low to median levels of these measures, with a diminished but still detectable gradient from median to high levels. And then you see a flattening of the curve from high to extreme levels of these measures, right? So the original empirical basis for this tenet was informed in part by a 1967 review article that was done by Antonovsky. And after examining 50 or so prior empirical investigations, Antonovsky concludes, and he writes, that despite the variegated populations, the inescapable conclusion is that class influences one's chances of staying alive. Variegated. Does anyone know what variegated? When I saw it, I didn't know what it meant. Anyone know variegated? Take a guess. Anybody do flowers, gardening? Multicolored. I saw it. Yeah, multicolored. Yeah, so it literally means having a variety of color. And as it turns out, nothing could be further from the truth as relates to the studies that Antonovsky did. Of those 50 studies, race was mentioned twice. In one, all the participants of color were placed in another category, or the infamous other category, and no analyses were done for those. And in the second one, the authors report that the blacks were disproportionately in the lower class and saw no reason to include them in the analyses, so the analyses were only done for whites, right? Also, the studies reviewed in Antonovsky's work were conducted almost exclusively with men. So we have this construct, socioeconomic status, right, that was developed, confirmed, and validated almost exclusively with a single demographic, white men, but that we use and apply liberally to all other demographics, right? Now, to be fair, this is due in part to data limitations. And what I suggest, or what I argue, is that when folks reference this study or other studies that have these kinds of limitations, they need to acknowledge it. Unfortunately, that doesn't happen very often, right? So, the legacy of these studies and others is that they highlight a trend towards a lack of careful consideration for the differences and distinctions between the constructs of race and ethnicity, and conceptual clarity when defining these variables in much of public health research. And it's actually slightly bigger than public health, because in other allied health research, as it turns out, this is the case. So in a review, or two review articles, one is from health services, the other from nursing research. So 121 studies were reviewed in health services, and of those 121, not a single one defined the race and ethnicity variables, right? And roughly 75 to 80% of allied health research actually examines something associated with race or ethnicity. In nursing research, of 167 studies, 5 defined race and ethnicity, but didn't make distinctions between the two constructs. Combined, these practices reflect the dearth of advanced theories of the relationship between race, ethnicity, SES, and health, and for that matter, also gender. And I argue that this absence of advanced theories that consider the relationships between these constructs may serve as an impediment to integrating the full range of findings that we have from studies examining these constructs. The result of this is that the magnitude and sometimes even the direction of the SES health relationship varies in ways that are typically considered unanticipated. Some folks would say unexpected. I've been using the language of paradoxical used to describe some of these findings. Now, to be clear, I am not suggesting that conventional socioeconomic indicators and the material resources associated with them don't matter for health. I hope they do. I spent a lot of time getting this education and this fancy job at Duke that actually pays me slightly less than I thought it would, to believe that they don't matter. So, to be clear, what I am suggesting is that simple attempts to redistribute conventional socioeconomic resources may not address the fundamental challenge of racial and ethnic health inequality, and that is that there may be some unmeasured social-cultural privilege associated with being white American in the U.S. that confers health advantage with increased SES that does not operate similarly for populations of color, right? And that for some populations, the cost and benefits of acquiring and applying these resources may vary in ways that are not well accounted for by existing models, and that when this is the case, other resources, other influences on health and quality of life indicators should be accounted for, right? So let's take a look at some studies that highlight this phenomenon. The well-known Latino health phenomenon, also called the Latino health advantage or the Latino health paradox, commonly described as low SES without expected poor health, right? It's most well documented with Mexican immigrants to the U.S., but there's also empirical support for Central and South American immigrants, right? And it's been found across a number of outcomes, including mortality, birth outcomes, hypertension, etc. A second, less well-known and discussed Latino health phenomenon is increased SES being systematically associated with decreases in more compromised health. And so this is over time for recent immigrants to the U.S. and intergenerational, right? So parents to kids to successive generations. Another study that highlights this phenomenon is a 2003 investigation by Gould and colleagues where they utilized a multi-ethnic sample of mothers to examine the influence of known behavioral and social demographic risk factors, including SES, on birth outcomes. So, U.S. white mothers had a favorable risk profile and, as expected, positive birth outcomes. U.S. black mothers had an unfavorable risk profile and, as expected, negative birth outcomes. South Asian Indian immigrant mothers had a favorable risk profile that was actually slightly superior to that of white mothers, right? But birth outcomes that were remarkably similar to those of U.S. black mothers. While Mexican immigrant mothers had a profile that was similar to that of U.S. blacks. Actually, on the conventional SES measures, they were doing slightly less favorable, worse than the U.S. blacks, but birth outcomes that were remarkably similar to those of U.S. white mothers, right? So factors that protected health, in this case, birth outcomes, for the U.S. white mothers, didn't do so for the South Asian Indian immigrant mothers. And factors that compromised health for the U.S. blacks didn't do so for the Mexican immigrant mothers, right? Oh, and I should also, if you have questions, clarifying questions during the talk, please stop. If you have substantive questions, I want to say save those until the end, but it'd be best if you didn't ask those at all. So, and finally, in a 2006 study, Lauderdale compared birth outcomes for a multi-ethnic sample of mothers 6 months before and 6 months after the events of September 11, 2001. And she found no difference in birth outcomes for black, white, Asian Pacific Islander, Native American, and Latino mothers. Arabic named mothers, however, had a significantly increased risk of preterm delivery and low birth weight in the 6 months immediately after September 11th versus the 6 months before, right? Moreover, those infants who had a distinctive Arabic first name were at greater risk for adverse birth outcomes, right? And Lauderdale hypothesizes that ethnicity-related stress or discrimination during pregnancy, reflecting anti-Arab sentiment in the post-9/11 period, may have compromised birth outcomes among Arabic named mothers. So, to summarize, frameworks and models based exclusively, heavily, or uncritically on conventional socioeconomic measures may mask important heterogeneity between and within population groups considered homogeneous, leaving unclear distinctions between race and ethnicity, overestimate the benefits of material resources, underestimate the psychosocial and ultimately health costs of resource acquisition for some groups, and overlook the value of alternative social cultural orientations and resource networks. Again, resulting in findings that are widely considered unanticipated, surprising, and paradoxical. And to summarize the summary, right? Evidence suggests that current race, ethnicity, and socioeconomic measures may not adequately capture the lived social experience of many of the very populations who are at greatest risk for adverse health outcomes, right? So we have a problem. I propose that a more inclusive and consequently comprehensive conceptual framework may reconcile these findings such that they are not considered unanticipated or paradoxical. To do this, we should acknowledge the broader social cultural context of race-making in the U.S., carefully consider conceptualization of racial assignment and ethnic identity formation, highlighting distinctions between the constructs, consider the health impact of hybrid coping associated with various forms of discrimination, and aspire to account for both conventional, that is, socioeconomic resources, and, to the degree possible, alternative resources and their impacts on health and well-being. And I have such a model. So, in this framework, a dominant social-cultural orientation has constructed a society, or members of the dominant social-cultural group have constructed a society such that they have relatively unfettered access to the conventional socioeconomic resources, right? High-quality education, prestigious, well-paying jobs, and that these resources readily translate into improvements in health status. This social order has also constructed a society that is stratified and hierarchical by racial categories, right? And mechanisms of institutional discrimination that members of racialized groups have to negotiate to gain access to these conventional socioeconomic resources. I argue that this negotiation comes at a cost, and so the returns that members of racialized groups can expect to gain upon application of their education, whether or not the education translates into employment similarly, whether or not they're compensated financially similarly, and whether or not the financial resources that they have in terms of if they apply for a bank loan or if they actually get that, they're getting the same return on those as majority population, right? In response to being relegated to an inferior position in the stratified racial hierarchy, members of these groups here in the United States of America may develop alternative social cultural orientations, right? And resources associated with these that they use to negotiate their health status and to more effectively engage and negotiate these mechanisms of institutional discrimination, right? So, alternative. Finally, the populations of color whose primary socialization occurs outside of the United States of America, that is, they don't have to contend with the direct specter of this racial imposition, have the benefit of an ethnic identity formation, not bearing the burden of this. The alternative resource networks associated with those that more effectively assure positive health and help them to negotiate institutional discrimination. So the crux of it here is we have the racial imposition, we have ethnic formation within the context of that, and we have ethnic formation outside of the context of that, right? So folks of color who are born in the U.S., what they contend with, folks of color who immigrate to the U.S. from other places, right? And we have a whole set of hypotheses that we're attempting to test using this model, and so I will share some of those with you all in a bit. So first, let's offer a conceptual definition of ethno-racial assignment, or race, which we define as a system of popularly held classifications that have been and are currently politically, socially, and economically advantageous to the dominant group, while being simultaneously disadvantageous to other groups. Race is a social imposition that has been institutionalized over time and consequently best viewed as a structural factor, right? Not about individuals, but instead a set of mechanisms built into government, society, and culture that reinforce and support a stratified color-based system. And I argue that there is an aspect of race-making in the U.S. that is cultural, right? And that's on the part of the dominant group. We'll talk about that a little later. Ethnicity, on the other hand, is a set of beliefs, values, practices, and portrayals which are self-constructed and comprise indigenous institutions with positive social value for the population that they're associated with. These provide agency, right? And so ethnic identity, again, may be constructed within the context of the racial imposition. And when this is the case, it manifests as a resistant social cultural response, as is the case with Black Americans. Or outside of the direct imposition of this stratified racial social order, as is the case with Mexican immigrants. And in this case, it manifests as a traditional social-cultural orientation that many immigrants bring with them when they come to the U.S., right? Now, despite this, once those immigrants arrive to the U.S., you can best believe that they get subjected to this racialized or this racializing process. Vera Fuentes describes this process as othering, and she suggests that increased frequency and intensity of interactions with a dominant cultural orientation supportive of this racialized society, coupled with increasing awareness, right, of where you fall out in that hierarchy, is distressing, both psychologically and physically, and over time, compromises the health of Mexican and other immigrants to the U.S., right? So they learn not just what it means to be American, but what it means to be an American of color. Right? Historically, this is manifested as slavery of black Africans, genocide of Native Americans, differential immigration policy, targeted marketing, residential segregation, negative media portrayals, etc., etc., etc. So to summarize, 3 social cultural orientations: a dominant racially discriminatory social cultural orientation, and 2 alternative ones: a resistant one, resistant social cultural response, and a traditional one. Right? So if we think about the Lauderdale study, that provides, I think, a pretty good natural experiment of what happens when folks are forced to contend with some sort of marginalization or discrimination. But consider populations who've been here for extended periods of time and across multiple generations. What Sherman James and Arlene Geronimus refer to as high-effort coping, and it's defined as the process of actively engaging biased and discriminatory social institutions that require personal resource expenditures that are taxing and distressing and, again, impact health over time, right? And the gist of this entire thing, for me, is that there's a social cultural context, right, that essentially constantly degrades an individual's, families, and even populations' dignity and integrity by challenging their very right to exist for the truth of who they are, right? So that's the crux. When someone asked me earlier the difference, or why I use the term structural inequality or health inequality versus health disparities, this is part of it. I argue that this is structural, that is woven into the very fabric of what it means to be American, not just historically, but in contemporary times. And unless we think about it in more critical and progressive ways, I don't imagine that it's going to change very much anytime soon. Right?
Can I ask? I think I'm trying to figure out, so you brought up institutions and you also brought up psychological factors.
Yeah.
I'm trying to figure out if the mechanism you're kind of thinking about is more institutional or more kind of like psychological stress.
I think it's both. And so what I would argue is that engaging these institutions actually can be psychologically distressing, right? Does that make sense?
Well, yeah. I guess my question is it just the institutions, or is it just the health institutions, or is it the institutions of society?
No, not health institutions. These are much broader, like societal level institutions. Yeah,
okay.
And I'm going to talk about some of those in just a minute. Yeah.
Thank you.
Good question. But no, I'm not talking about healthcare and what happens here. I'm talking about the country. Yeah, talking about the country. Yeah, good question. So, oops, sorry about that. So the 2 examples are John Henryism and the weathering. Are you all familiar with John Henryism and weathering hypothesis? Okay, some of you are, most of you are. Well, for those of you who are, you can share with those who aren't. But we can talk about that. So let's go back to the model. So in any society, right, the top half of this operates. But in a country like the United States of America, again, we have to very carefully consider everything that is happening here on the lower level. So speaking generally, to the degree that marginalized populations are able to tap into resource networks, practices, ideologies that provide meaning to them and resonate with confirming or affirming aspects of their primary socialization, it is health promoting. To the degree that they're pushed out to the fringes and marginalized, they those practices are health compromising. So the framework then offers a consistent explanation for both Latino health phenomena. For recently arrived immigrants of color with low levels of conventional measured SES, maintenance of their traditional cultural orientation will be health protective. However, as they or their children access greater mainstream socioeconomic resources through engaging the educational system, the job market, lending institutions, etc., they are more likely to encounter stress associated with various forms of discrimination. While they may rank higher on the conventional SES measures, their health may be compromised. So the very aspect of the Latino health phenomena most frequently considered paradoxical may in fact be health protective if being low SES, right, means less frequent interactions with these institutions that comprise the discriminatory practices, right? Yes?
Are you going to, when you talk about health status, are you going to talk about the sources of kind of degradation in health status? Like, because when you're describing this story to me, it makes me think of nutrition and the fact that when immigrants come to the U.S., they're primarily eating a diet that they're familiar with, at least they attempt to. And then as they start to make more money, they eat more processed food, right? And that interaction is also by seeing what kids at school eat, and then what becomes more convenient as mom and dad start to work more. And so what I'm wanting, of the variations that you're going to look at in your model, how much of that is coming through diseases related to what people are eating, like in particular heart disease, diabetes, obesity? Are you going to talk about like the distribution of the health effects and the kinds of health effects that predicted by your model?
Very good question, and yes, I will answer each and every one of those. So yes, 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 no, and yes.
Gotcha.
No, that's a very good question, and thank you, because you just set me up pretty nicely for what I'm going to talk about next, right? So, 3 empirical investigations. One, which looks at the health of the Mexican origin population in the U.S., and it's specifically for those who immigrate to the U.S. The second looks at an ethnic white population in the U.S., so we examine the health and well-being of Jewish Americans in comparison to non-Jewish whites, non-Jewish blacks. And the third looks at variable race and ethnicity designations and how the way that we conceive of and conceptualize race and ethnicity and nativity too actually impacts what we see in terms of our outcome, which is separated health, right? So, stress, allostatic load, and the health of Mexican immigrants. And so in this investigation, we were interested in exploring the unhealthy assimilation effect often observed among Mexican immigrants here in the U.S. And the core question, and this is exactly what you just got at, is over time, are these recently arrived immigrants adapting unhealthy U.S. behaviors, or might this degradation of health be associated with stress associated with the process of acculturation? Now, the acculturative stress is really tricky because I would argue that it's very difficult to measure that directly, and I've for years and years I looked at the acculturation measures, and there's some challenges associated with those. And if anyone has a really good measure of acculturation, please send it to me. I haven't seen one yet that I thought was particularly beneficial. So, yes.
Those two, the second and third bullet, seem very similar to me.
What do you mean? So the first one,
the second and the third one.
Yeah,
it's like
well, the second and
the culture of stress is part of adopting unhealthy U.S. behaviors.
Trust me when I tell you they're different, and I'm going to prove it to you in a second. Or I'm going to do my best to prove it. Social science never proves anything. I will suggest how we went about doing that. But you're right. And so the thing, one argument could be our health behaviors or changes in health behaviors a response to the stress, right? So if people are distressed, will they eat more, maybe drink more, smoke cigarettes, go out to the club, stay up late, those sorts of things. Is that the argument? Okay. Good question. You guys have great questions. Thank you. But we're going to address that in just a minute. All right. So we use the allostatic load algorithm proposed by McEwen and other folks since, where we have a measure of physiological stress response, right? Primary mediators, so hormones that are released, secondary effects, how they impact the systems, which in turn affect health status. And our hypothesis are pretty straightforward. And the first is that stress exposure contributes to the worsening health of Mexican immigrants with time spent in the U.S. And then Mexican immigrants whose residents, who've been here for longer periods of time, will have a higher allostatic load than those who arrived more recently. So we use NHANES 3, National Health and Nutrition Examination Survey. Our predictor of interest was time in the U.S., so less than or equal to 10 years, 11 to 20 years, greater than or equal to 21 years. Our basic covariates were age, gender, which are our demographics, and poverty income ratio and education, and marital status. So the education and poverty income are our socioeconomic measures. And our extended covariate set actually gets at some of what you all were suggesting, is that we account for dietary intake, physical activity, smoking status, and healthcare utilization, right? And so with this model, did I see, was that a grimace? See it?
Yeah.
A grimace of skepticism?
Well, yeah.
Speak.
No, I'll wait.
No, you can speak. No,
I don't see job.
We don't have employees.
Yeah.
I wish we did. You could talk to the NHANES people and tell them they had it. That would be helpful.
We often talk.
Yeah. Yeah. And so with the extended set, right, what we're attempting to do is account for those health behaviors over time, if they're changing, right? So let's take a look. So logistic regression, so allostatic load time in the U.S. We run a set of models using the basic covariate set, so the social demographic and socioeconomic measures, and then the extended covariate set, those health behaviors and healthcare utilization variables, right? We use the weights and report results as odds ratios. And so in the restricted set, where we just have the social demographic and socioeconomic variables, we see that when compared to the reference category, which is those who've been in the U.S. for less than 10 years, those who've been in the U.S. for 11 to 20 years have increased odds of a high allostatic load score versus not having a high allostatic load score. And those who've been in the U.S. for greater than 21 years are even higher. Now, in the extended set, extended analyses, we introduce those individual health behavior variables, so the diet, the exercise, the smoking, and the health utilization. Yes, ma'am?
This is a question related to the set of covariates.
I can't hear you.
Is there any information in the data set about immigration status? I'm assuming these are legal immigrants and then also state.
Yeah, we don't have any information on whether they're here legally or illegally. It's just that they were born outside of the U.S. and immigrated to the U.S. We do have age of immigration, and did robustness checks, to be fair, after we actually published the paper, and fortunately our findings held up for once we accounted for those differences. So the important thing here is, if those health behaviors, right, what you eat, whether or not you're exercising, those sorts of things, if you're smoking or not once you come to the U.S., were responsible for these increases, introducing them into the model should have reduced these odds ratios, right? Does that make sense? Once we introduce them in, particularly for those who've been in the U.S. for greater than 21 years, the odds ratio shot up, right? Does that make sense to folks? Right. So those who are in the U.S. for longer periods of time, also in unadjusted models, had higher SES than those in the U.S. for shorter periods of time, and that higher SES did not result in improved health status for those folks. Right? And some of you may be familiar with the Simon bias. That is that one of the explanations for the Latino health advantage, or the Mexican health advantage, which is what it should be called, is that as folks get older, they return to their country of origin as they get ill, because they don't want to be ill here in the U.S., and they never show up in our morbidity and mortality statistics. And so if mortality is the outcome, right, they're statistical immortals because we never get them. But if the sickest people, right, the oldest people in our investigation have gone back to Mexico, they're not showing up in our statistics. And so this may actually be a conservative estimate of what's happening over time in the U.S. Right?
I wonder, do you have information about, I don't know if it would be household size or if it would be something to the like of if someone... I'm sorry?
Household composition?
Well, I don't know if it's a composition, but sort of, if someone comes here on their own over the border, whatever, as opposed to coming and living with family, which I assume would have a very different health profile.
In NHANES, we do not have have that
Don't
data.
you have, I think they have household size, don't they?
Yeah, they do have household sizes. Yeah, but we don't know anything about like who they're living with or anything like that. We just have a count.
Okay, but that didn't enter in the model or fill out or
No,
whatever?
we didn't. No, we didn't do it. But very good question. That's the other hand. Yeah.
Yeah, I'm curious about, we talked about before about immigration status being illegal, and the salmon bias to say that, like, if you're illegal, then it's probably not that easy to go back home.
If you're illegal?
I guess if you, then, yeah.
It's easy.
It's easy.
Oh, it's easy.
If you're illegal, you just can't get back in. or-
Yeah, that's the problem.
Okay.
You can go back. The problem is coming back to the States.
Okay.
Yeah.
But even with that, in California,
Folks
I worked
pass
in
back and
a
forth.
restaurant, and people went home regularly and
Yeah.
showed back up a couple months later.
Yeah, and to be completely honest and transparent, when I came back from the Peace Corps, I worked in migrant health for years and years and years, and I had a number of folks who got sent back, some as far as Guatemala, and 2 months later they were back in the States. And I don't know how that happens, I just know that it does, right? So, very good questions. Thank you. Any more before we move on to the next study? Okay. So, oops. Sorry. So in the next study, we were interested in exploring minor divisions, that is, the ethnic distinctions among the white racial population here in the U.S. What we propose is that some ethnic whites may have been relegated to a subordinate position within this stratified social hierarchy also, and so that there are distinctions among whites, right? So the population that we decided to do this work with was Jewish folks here in the U.S., and I should say my co-author Arlene Geronimus is herself Jewish, and that was important to me because I didn't want people to come after me for doing work on. Can I tell a story real quick? All right. So when I went on the postdoc market, I did an interview with a noted Jewish scholar who was looking at my information. He looked at me, looked at my information, and threw my papers down on the floor and said, "J. Pearson, what qualifies you to do research on Jews in the United States of America?" Now, this is someone who has made an entire career of doing research on black Americans, right? And so me being, this is some years ago when I was young and kind of angry, my response was, well, I guess I'm as qualified to do research on Jews as you are to do research on blacks, and you've made a career of it, so we'll see if I can make a career on this, right? So I got some pushback, but ultimately, when the paper came out, he liked it. So in this study, we're interested in investigating some of those subtle distinctions by ethnicity within an assumed homogeneous white racial population here in the U.S. And part of it had to do with, despite popular opinions of how well Jewish Americans are doing on the conventional socioeconomic predictors, as it turns out, almost half of Americans, when surveyed, admitted to having some anti-Semitic sentiments concerning this particular ethnic population of white folks here in the United States of America. So, pretty simple, straightforward hypotheses. We hypothesize that Jewish Americans would be less healthy than other U.S. whites and more healthy than U.S. blacks. Jewish Americans with greater access to affirmation of their alternative social-cultural identities, whether religious or secular, will have better health than those with less access. And Jewish Americans of lower SES will have greater benefits from access to these alternative social-cultural identities than those of higher SES. Right? So the National Jewish Population Survey was the data that we used, and the National Study on Religion and Ethnicity, which was, for comparison purposes, blacks and whites. So this time we have self-rated health as the outcome. And for the demographic variables, we have age, gender, region of country, we have denomination. For the socioeconomic variables, we have education and income. And other predictors we were interested in were extent personal religious and proportion of close friends who were Jewish. And so this is a measure of Jewish identity and ties to the Jewish community. Logistic regression, and we included the demographic and socioeconomic variables, and then we added the variables for the cultural affirmation for the Jewish portion of the sample. Right? So, the non-Jewish white population is the reference category. And in our unadjusted model, we observe non-Jewish blacks being significantly less likely to report positive health versus negative health when compared to non-Jewish whites. Jewish Americans, not significantly different. We introduced the education variable, and now we see both non-Jewish blacks and Jewish Americans being significantly less likely to report positive health. Similarly, when we introduce income, and when we introduce education and income simultaneously, we have some convergence here. Jewish Americans and non-Jewish blacks both being similarly, significantly less likely to report positive health relative to the reference category, non-Jewish whites. So this is just for the Jewish proportion of the sample. We were interested in the effects of the proportion of closest friends who were Jewish. So in the unadjusted model, and this is just the demographic variables, the reference category, was about half of your close friends being Jewish. Those who report less than half of their close friends being Jewish were significantly less likely to report positive health. Those who reported more than half of their close friends being Jewish were significantly more likely to report positive health. Introducing the controls for education and income, same. Those with less than half friends were not significantly different. And once we introduce the control for religiosity, we still see that those who report more than half of their close friends being Jewish were more likely to report positive health relative to those who didn't. And then the final slide that I'll present to you on this. So the proportion of closest Jewish friends, closest friends who are Jewish, we're interested in seeing whether or not where you fell out in the socioeconomic hierarchy had implications for the value of your friendship networks, right? And so as it turns out, if you had greater than a high school education and more than half of your close friends who were Jewish, those who had this, or who had more than half of their close friends being Jewish, were significantly more likely to report positive health. Those who had less than a high school education, and to be fair, this is only about, I think it was 16.8% of the total sample, that the odds ratio for those who had less than a high school education and greater than half of their close friends Jewish is higher than.
Out of curiosity, were those people on the far right pretty old?
That's a good question. To be completely honest with you, I don't remember.
Because they were Jewish, they didn't have much education, but they had a lot of Jewish friends.
Yeah, but we also, so we controlled for age. You're asking if we looked at just the distributions. I don't remember off the cuff. I know we did it, but I do not remember. I can take a look and send you an email if you would email me and let you know. Right?
While we're asking questions, I'm unfamiliar with the survey that you used.
Most people are.
As a Jewish American, I'm surprised. But I don't know if you have a breakdown of what that population is.
What do you, in what sense?
What's the national Jewish, use a national Jewish population survey or something?
Yeah.
I don't know.
Anything about the survey?
Yeah, I don't know. I'm just wondering, is it a national?
It's a nationally represented sample. Yeah, random digit dialing.
Oh, it is?
Yeah.
All right.
You want to work on some stuff?
Well, no, I just, sort of anecdotally, my boss says no.
They never called you.
Yeah, first of all, they never called me. No, second of all, I'm just curious, I'm sure you did this denomination stratification.
Yeah.
But, there's a real difference between secular and, a black hat community. Yeah. So, and certainly in terms of being a no more than high school, but all your friends Jewish kind of thing. So, they seem like very different populations, truthfully.
Yeah, they are. But we got published, so we can talk about
Okay.
that. Yeah, no, that's and in fact, part of what we're doing right now is checking out some of that stuff, to be completely honest with you. And I would love to share with you what we found, but I've been told that I can't. My boss told me I can't. And so, the findings generally support the hypothesis and the framework. And to be fair, again, due to data limitations, because proportion of Jewish friends, proportion of closest friends who are Jewish, and also the issues associated with denomination, because we did stratify by denomination and look at it, and there's some interesting stuff going on there, right? Yeah. So the very last study, which I'd hoped to have submitted for publication by now, but teaching takes up a lot of time and energy. There's one that I started, I guess, about a year ago. I've been playing around with. And so again, in Haynes, self-rated health is the outcome variable. And I use different designations for the race ethnicity variables. Covariates, the conventional demographic stuff, the conventional social economic stuff, and the individual behaviors. So let me just show you what's going on. So the hypothesis is a general one, and essentially what I'm arguing here is the way that we conceptualize race ethnicity variables has implications not just for the models, right, for how we run our analyses, but also for the relationship between the variables themselves and the outcomes. And so we need to be really careful when we talk about race ethnicity. So the unadjusted model is just the demographic variables. The restricted model introduces the socioeconomic controls. And the extended set is the individual behaviors. And so reference category is whites. This is blacks, significantly less likely to report positive health. The other category is problematic, but I decided to include it for power, for statistical purposes. So the real story is nothing that we introduce actually moves the blacks relative to the whites. And so introducing the socioeconomic controls, introducing the health behavior controls does not alter the likelihood of blacks to just consistently report unfavorable health relative to whites. Once we introduce the socioeconomic controls, we observe both those of Mexican origin and those who are in the other category being significantly more likely to report positive health relative to the whites, the reference category. Right? So in the second set of analyses, we used just the proportion of the study, the folks who were born in the U.S. So we pulled out the immigrants, right? And again, for the blacks, nothing moved it. Not the socioeconomics, not the health behaviors. In the unadjusted model, for the Mexican origin population here in the U.S., and these are folks of Mexican origin who were born in the U.S., no foreign-born folks here. In the unadjusted model, they were significantly less likely to report positive health, but once we introduced the socioeconomic stuff and the individual behaviors, no difference. Right? So let's look at the foreign-born folks. So foreign whites are the reference category. So each of the populations of color were less likely to report positive health when compared to foreign-born whites, but we introduced the controls for the socioeconomic variables. They were slightly more likely to report positive health, but not significantly so. Similarly, when we introduced controls for the individual health behaviors and healthcare utilizations. Yes?
I'm trying to make sense of this with what you said earlier.
Good. Me too.
So, I mean, this would suggest that foreign-born people have less problems with institutions than broadly defined than people. But I would think that doesn't strike me as likely because they have language barriers and the degree of work it takes to figure things out in a foreign country for me is a lot. And I can't imagine that suddenly they have it easier. I don't know. What does that mean to you?
She's going to answer your question.
Yeah, me too. I think there's a difference between the barriers somebody who, say, came from India has in trying to engage in institutions in the U.S. versus someone who is of African American descent, born and raised in the U.S., and the types of discrimination or kind of barriers to institutions that they experience. And I think given U.S. history, and my knowledge in this area, being Canadian-born, is it's not that great, but just from observation, it seems to be me that it's more ingrained than it would be if somebody who was born in India came here and had a bad experience. Maybe somebody, for example, when we were little, my dad, people started like mimicking what sounded like belly dancing music, even though we're Indian, at him while we're driving around LA. So it was like a racial comment that made him upset, but at the same time, it didn't have anything to do with his core identity as an immigrant in the U.S., whereas I feel like that is not comparable to what kind of imposition a black person born in the U.S., given black history in this country, experiences. I think you're just not comparable.
I think you're getting close to it. So I'm not suggesting that folks don't encounter some things that they get here. And there may be a selection effect, right? Because folks who are coming from the U.S. may not be representative of, the entire population of folks where they come from, particularly people who come from far away. So there definitely is some selection.
And is the argument that you read it differently? Like, you expect to have a ton of problems
and
in
so,
a foreign country, but you don't expect to have a lot of problems. Or, like, it's differently stressful to have a lot of problems when
so
you...
what I would suggest to you is, and I think you're alluding to this, and this is what the framework predicts, right, is that if your primary socialization occurs here, and you're familiar with this stuff, and you've had to contend with it all of your life, and your parents and your grandparents, and there's intergenerational transfer of what this stuff looks like and how it's likely to impact you, you pick up on it, right? Whereas if you come here, you have these wonderful hopes and dreams and aspirations of what this is going to be like, right? You don't know this stuff, but I bet you, stay here long enough, we'll get you, we'll help you to understand what it means, right? So that's what, yes.
The other thing that came to my mind was about, and this is more of an econ kind of framework, is, so they had like, individuals have this optimization problem where they have to think about the benefit of getting healthy so that they can work and make money, because the net payoff of investing in your health makes you more likely to work every day and you can bring that income in and spend it whichever way you want, versus not really caring and what's the benefit if I'm healthy or not healthy, life sucks anyways. So I kind of feel like that opinion of economic opportunities, when folks come from other countries, they do have these kind of American dream ideas which seem to go away quickly, I think, but they're also very gritty and have low expectations of kind of everyone, and they're just in it to fight, versus if you have this ingrained idea of your economic opportunities being very limited, then you solve that optimization problem differently. And it could be that those economic opportunities are, in fact, very limited, and so then why are you going to invest in your health when what are you investing in your health for?
Good points. Yes, sir. Wait, are you the boss?
I'm one.
Okay. Good.
So, I know you've spent a lot of time discussing your model, and this is a very U.S.-centric model, it seems.
Yeah.
And I'm wondering if you've thought about how it can be applied to another country.
Yeah, I have.
And not just international migration, but internal migration, say, in Guatemala or Honduras.
Yeah.
Coming from the Bataan or something like that.
Yeah.
Or in Brazil, where a lot of people are now going there because it's... And I would think that your model, some parts would work, some parts wouldn't.
Yeah.
And it would be a lot stronger if it could just be applied everywhere.
Yeah, right? And I wish, and absolutely correct. The system that I am most familiar with is what we contend with here in the States. And I did my Peace Corps training in Honduras, and I liked it so much that it was hard for me to stay in the States. So for years, every 4 to 6 months, I was going back to Honduras for a couple of months, right? And I've thought about this in terms of the social stratification there. And I had conversations with folks, with friends of mine who are in universities there, and what they say to me is, listen, in the U.S., you guys have this black-white race dichotomy, right? Everything else sort of falls in between that. In Honduras, they have 27 different skin color descriptions, and the hierarchy falls out stepwise by those skin color descriptions, right? So there, my brother, who is significantly darker than I am, and my mother, who's very light-skinned, we would be assigned to different skin color groups there. And so one of the challenges is tailoring this thing to fit whatever the hierarchy might happen to be there. And that doesn't say anything about differences in economic opportunity and access to things like education. in a system like that. And so it's something that I thought about. I think it can be tailored and adapted, but it would take folks in those countries who know much more about the socio-cultural and socioeconomic milieu in history than I do to be able to do that well. So, yeah. You look skeptical.
Well, it seems to me that you could describe a model that would be general enough,
Yeah.
that could fit, and it wouldn't matter what divisions of race or ethnicity a country has, right? I mean, you just know that that exists.
Yeah. We can try.
And I think the interpretation of how that model is used within the country, that's when you need the experts within the
Yeah.
country.
Okay. Well, then I guess that's my challenge. I'll be sending you an email, actually. We can talk about it.
Send it to her.
Yeah. But no, I think that's worth doing. To be honest with you, it was hard enough for me it was a challenge for me to get this first one up and running, and this is something that happened over time, but I agree with you. I think that's stuff that happens over the course of a career, right? But thank you for that. That's a very good point. Very last slide of findings, and then I think we're about at the end, right? So, so in the last model, U.S. whites are the reference category, and I compare all foreign-born and U.S.-born populations of color to U.S. whites. And, you know, the big story here is each of the foreign-born populations, right, regardless of if they're here in the U.S. or white, black, Mexican origin, or other, all were significantly more likely to report positive health versus negative health when compared to the U.S. whites. The one population that remained significantly less likely to report positive health compared to U.S. whites was U.S. blacks, right? And so this suggests then that maybe what we call racial and ethnic health disparities in the United States of America are really about the black-white race dichotomy, right? And that when compared to each of the immigrant groups, white Americans clearly are not doing better, they're doing significantly worse. When compared to either of the other two groups of color here in the United States of America, they're not doing significantly better. It's only when directly compared to U.S. blacks, the U.S. whites look like they're doing well. So maybe there's something about that black-white race dichotomy that's bad for all of us here in the United States of America. Right?
Black and white.
Yeah, well, it is black and white, yes. But there's a lot of color in between. So that's the end. So we can talk.